Senator Bates.
Thank you. Yeah.
I believe Senator Hall asked if his bill, if you guys don't mind. Oh, okay. Okay, which item number, Senator Hall?
SB 779.
23779, skilled
Yes.
nursing facilities, certified nurse assistant staffing.
That's correct. Mr. Chair and members, I would like to begin by accepting the proposed technical and clarifying amendments noted in comment 8 on page 6 of the analysis as author amendments. I am also willing to accept as author amendments the suggestion by the chair to delete the language found on page 19, line 14 through 18 of the bill, and thank the committee staff for their assistance with this legislation. SB 779 requires skilled nursing facilities to publicly post at all times the number of direct caregivers on duty and assure a minimum number of hours of care provided by certified nurses assistants by instituting specified staff-to-patient ratios. CNAs are the primary caregivers, providing 24-hour care to residents 7 days a week, such as assistance with daily living, post-hospital and post-surgical care, diabetic management, and rehabilitation services. Current staff requirements, however, do not meet the direct care needs of nursing home residents. Operators of skilled nursing facilities are considered to meet the 3.2 nursing hours per patient care requirements, even when including personnel other than CNAs in the staffing ratios. The resulting chronic understaffing of CNAs create potentially unsafe living conditions for residents. Without enough CNAs to serve patients, these individuals are placed at risk for unnecessary falls, illness, or injury. Residents that receive subpar care are at a greater risk for hospitalization or being injured, resulting in increased health care costs. SB 779 helps to ensure that CNAs, the primary providers of care, are available to meet the needs of seniors, people with disabilities, and people recovering from illness or injury, and will help create a safer living environment for resident patients. I requestfully ask for your aye vote. We have Robert Harris from SEIU here to testify and to add any clarifying, to clarify any questions that that may be needed. Thank you for your time.
Thank you. Please proceed.
And consideration.
Mr. Chair, members of the committee, Robert Harris for SEIU California and for SEIU ULTCW, our long-term care local that represents 5,000 nursing home workers across the state. In respect for the lateness of the hour and the fact that I have little to add beyond what Senator Hall added, but to clarify one issue that sometimes comes up is the federal government has recommended certain staffing ratios, and it's 4.1, which is the most cost-effective for the outcome, for desirable outcomes. It's 4.1 overall. It's 2.8 for direct caregivers. The ratios that are put in the bill come out exactly 2.8. And the overall is at 4.1, which is, like I said, what the federal government decided was the most cost-effective way to get the best care in nursing homes. So that's what the bill does. It sets those as the standards. And I turn you over to someone who actually understands this because she does it every day for a living, Cynthia Hudson.
Hello, my name is Cynthia Hudson, and I work at a long-term care facility in Merced, California. I've only been doing this for 6 months because my father became ill. He has dementia, and he's in a long-term care home in Georgia. And we have to go back and forth to check on him. The staffing at the care facility that I care for, that I work for, we have a ratio of 10 to 12 residents per CNA during the morning, and we have to get people up for breakfast, and that includes giving 2 to 3 showers every morning, brushing their teeth, getting them dressed, and getting them over to breakfast before 7 o'clock. And then we have, when we have more than 12 people, sometimes if someone has to, they send someone home after the breakfast crowd is gone, they send a person home, then you end up with more than 12. people to take care for. Two of my residents, since I've been there, stopped breathing on me, and it happens. When that happens, I'm not able to give my attention to any of my other residents that I have. Every time something happens, whether they get sick, they throw up, anything, we have to take their first priority, and the rest of my residents go by the wayside. These are people who have worked their entire lives and raised their families and are now living in long-term care. This is their home, and this is the rest of their lives they will be spending there, and they are elderly, and they deserve to have the best care that we can possibly give them. I hope that we have your support to change the ratio of the residents per CNA per bill SB 779, because it is greatly needed. The less residents we have, the better care we can give them.
Thank you. The remainder, if we can just state your name and position, please.
Lisa Coleman, Executive Director for CalCOA, the California Long-Term Care Ombudsman Association, in very strong support.
My name is Teresa Hernandez, I CNA, I support. Maribel Ruiz, CNA, I support.
My name is Maria Munoz. I'm CNA. I need support.
Linda Vidaca, Certified Nurse Assistant. I strongly support.
Hello, my name is Yolanda Hernandez. I'm a CNA and I strongly support as well.
Hello, my name is Berta Contreras, I am support.
My name is Maria Vasquez. I am CNA. I'm support.
My name is Markenza Dias from SEIU, ULTCW. I strongly support SB 779.
My name is Grace Butler. I'm from SEIW, and I strongly support 779.
My name is Zenobia Lee. I'm currently a CNA, and I support Bill 779.
My name is Sheila Mansang, SEIUW. I strongly support.
Sandra Reyes, CNA, strongly supports 779.
David Stone, CNA, strongly support SB 779.
Hi, my name is Angeles Perez. I support SB 779.
Maria Gonzalez, I support ABC 79.
Hi, my name is Maria Ibarra. I support SB 779. Thank you.
Hi, my name is Angelica de Arcos, and I support SB 779.
I'm Christina Lockyer, Bakersfield, California, CNA, and I strongly support.
Marta Garcia, CNA from Los Angeles, and I strongly support SB 779.
Alejandra Morales, I'm CNA, and I'm support SB 779.
This is Milagro. I support SB 779.
I'm Nancy Bang. I strongly support SB 779.
My name is Hoya Hazem. I'm a certified nursing assistant and an administrative assistant of psychiatric outpatient clinic. I strongly support SB 779.
My name is Selena Ortiz. I support SB 779.
My name is Esther Allegian. I support SB 779.
My name is Maria Maral. I support this bill.
I am Rosa Rodriguez. I'm Nurse Assistant CNA. I strongly support SB 779.
My name is Don Ammon. I'm a CNA and RNA, and I support SB 779.
My name is Dolores Solorzano. I am CNA and I am approved.
Hello, my name is Abigail Ramirez. I'm a CNA and I'm support. My name is Rosario Acosta. I'm CNA. I'm support SB 779.
My name is Ines Lonting. I support SB 779.
My name is Aida Lara. I am support SB 779.
779.
My name is Francisco Carrillo. I am support P779.
Shirley Titman, licensed vocational nurse, and I strongly support this bill.
My name is Alma Lozano, and I support SB 779.
Thank you. Opposition?
Mr. Chairman and members, John Latimer on behalf of the California Association of Health Facilities. I certainly appreciate the amendments that the author took. We certainly appreciate and value very much the staff that showed up here today. They're critically important to running our buildings. Unfortunately, the California Association of Health Facilities, we do not support staffing ratios of this kind, and we've spoken with the sponsors about that previously, and we'll certainly continue the dialogue with them. Staffing is critically important in our buildings. However, the staffing reimbursement model that many of the advocates, including SEIU, worked with us to develop over 10 to 12 years ago was a model that was designed to recognize the individual needs of each facility. So the concept behind that was we want to be sure that we reward those facilities based on their staffing patterns. Once they meet the minimum nursing hours, those who go beyond, we're going to continue to reward and provide additional reimbursement for those facilities because they're staffing at a level that meets the acuity need of their patient population. And that we do think is critically important. So while we disagree with the approach here, we very much value and in fact, want to continue to work on, how do we develop more staff into our buildings? We're certainly in favor of that. The minimum nursing hours we currently have in our facilities are 3.2 nursing hours. The average is 3.7. I would argue the reimbursement methodology is driving the right kind of decisions. We are seeing people staff at higher and higher levels in these buildings, and that's the right way to do it, but it needs to be, again, on a facility-specific basis. So in other words, we may need, in some cases, more RNs than we do CNAs or more LVNs than we do CNAs, and that's the important element about how we figure out what's right for the patient need. Again, the CNAs that spoke here today, and again, are much the backbone of our facilities, are critically important. There's no denying that. However, we have to look at the total needs of patients and the total needs of the healthcare or the health delivery system that we are running. So, big picture, that's our largest concern. I would say, we've done some initial analysis, and our initial figures come back that the cost of this proposal is $500 million in Medi-Cal funds. We looked at about 22 million Medi-Cal days, and we've done some analysis looking at OSHPD data our folks are very familiar with, and we've come up with our initial estimates, and certainly we'll look at this more in the fiscal committee, but it's about $500 million, of which about $250 million is state costs, and of course $250 million federal cost. Unfortunately, there's also another approximately 11 million days that are Medicare reimbursed days. And our population in nursing homes are almost exclusively Medi-Cal and Medicare. We don't have a lot of private pay. So the other third of our patient days to which this requirement would be assigned, there is no reimbursement for. And those costs would be, again, then be forced to absorb by the operators. That's about $250 million to this industry. That is very, very difficult to absorb at a time that we're trying to get our Medi-Cal business back up to dollar for dollar even on costs. So incredibly expensive, not designed the way that we think on a facility basis it should be. And frankly, if the state, setting aside the unreimbursed costs, if the state were to say that we have a desire to invest $500 million, we absolutely would be hiring more CNAs, but it would not be probably the model that we're describing here. It would be much more on a patient or a facility-based basis looking at the patient needs in those facilities. So regretfully, we cannot support the bill. We're certainly going to continue the dialogue and know that staffing is critically important to us. We appreciate the passion on behalf of the supporters here, but we just do not agree with this methodology.
Thank you. Anyone else in opposition?
Chair, members, Jeff Hampton on behalf of Leading Age California. Leading Age California is an association of not-for-profit senior affordable housing, home and community-based services, assisted living, and skilled nursing communities. I would associate many of our sentiments and concerns to my colleague here on the right as well. Another concern of our membership is that getting staffing up to that level, particularly in certain areas here in California, will prove to be a rather difficult challenge. many of our members are already having difficulty getting those staffing levels up to desired levels. And I would again agree with my colleagues to the right that most of our facilities staff well above the 3.2 minimum anyway. But we do compete with CNA, or for CNAs with other healthcare entities like hospitals. And so we recognize that that can sometimes be a challenge to find the adequate workforce that we're seeking. So that is a concern of our membership. And otherwise, again, I would associate my comments to my colleague on the right. I do appreciate the authors and sponsors bringing this forward, though, and we do look forward to working with you.
Thank you. Comments, questions from any of the members? Yes, Senator Mitchell.
Thank you. I understand that 3.2 hours is the current minimum. What would this bill take it to? Is it framed in such a way that you could do an apples to apples comparison?
To the chair, it would make it 4.1, which is the federally recommended amount. Okay. And in fact, 63% of the facilities in California right now are staffing above 4.0. So the 3.7 average is taking the people who are doing it where this would end up saying was the floor, and averaging people who are way at the bottom. So this affects the people at the bottom more than the people at the top.
Got it.
Mr. Chairman, if I may just respond on that same point. I know time's short, I promise. The one thing I would say is it's a two-part test. It is the overall hours, then it's also within that the ratios. You have to meet both tests, and so that makes it a very difficult financial calculation. Again, we're going to worry about that in appropriations, but it's not simply a one-tier test. The other final point to Mr. Harris has brought up the study a couple of times. There are no federally adopted guidelines on the staffing in nursing homes. There is a report that he cited several times, but it was a report. There are no adopted federal guidelines. So that issue certainly continues to be debated and will be at the federal level.
One more question, please, if I may, Mr. Chair, of the opposition. So I'm going to repeat back to make sure I understood conceptually your point that your association generally doesn't support staffing ratios because of the way of the reimbursement system is designed. You feel that your members kind of self-police, A, and B, that you determine the ratios of what level of professional, RN, LVN, certified nursing assistant, is appropriate based on their, so then there's no kind of agreement or discussion about appropriate ratios across the board. It's all kind of based on individual organization and their assessment of client need?
Yeah, Senator Mitchell, not left to us alone. Every year we have evaluators come in from the state and they look at our staffing model and the patient needs, and certainly first whether or not we're meeting the minimum staffing thresholds, and then whether or not we're staffing to the needs of the patient population we see. So it's not left solely to us, our discretion. That being said, back to your primary question, no, we don't like these kind of models. Yes, we do think that the reimbursement methodology and the acuity levels of the different facilities, we think drives people, and evidence exists, drives people to staffing according to both, what their needs are. There's no perverse, I think what others in the working groups would have said a dozen years ago, there's no perverse disincentive to hire more staff, because now you can go above those minimums and it's recognized. It is compensated by the state, and that's a good thing. So if my facility has higher medical need patients, I may need more LVNs and RNs, and I'm going to be compensated for that, even though my individual staffing costs may be higher than his costs, and he has maybe twice as many CNAs as I do, because the patient level need is a little bit different in there. Again, CNAs are critical in both facilities, but we're able to not one size fits all, and we do think, given the range of our 1,200 or so nursing homes across the state, we do think that makes sense.
What state agency sends the evaluators?
Department of Public Health.
Not the state hospitals, just straight Department of Public Health. Okay, thank you.
I believe Nielsen first, and we'll go with Roth. Is that correct, Senator? No, Senator Roth.
I want to make sure I understand. So if you have a particular skilled nursing facility with a high acuity patient load, you would necessarily, whether this bill passes or not, maybe need to staff up with more registered nurses and LVNs to care properly for the patients in your facility. Yet, if a staffing ratio is put in place with respect to CNAs, in addition to having the RNs and the LVNs to care for the patients, you would of necessity have to add CNAs, whether or not you needed the CNAs to care for the patients?
That's correct.
But right now, as a group of skilled nursing facilities, your observation is the skilled nursing facilities adjust the employee complement based on the nature of the patient care that needs to be provided,
Right.
and if
While always meeting the minimum staffing, which again, as we said, of course, the average per facility now is well over the minimum nursing hours of 3.2. There's still always that threshold that has to be met per patient day. But beyond that, you are, yes, adjusting and flexing based on your patient population.
So it would seem to me from an economic standpoint, if you could service the patients with the CNAs, you'd service the patients with the CNAs as opposed to trying to recruit, retain, and pay a registered nurse to do what a certified nursing assistant could do.
Again, to be really clear, CNAs are critically important to the facilities. However, there are limitations according to their license, what they can do, and certainly the patient need.
But I'm talking about scope of practice.
Yeah, so again, you're creating a clear economic argument, and simple economic theory would be yes, if you can accommodate it with a less expensive employee, you would. But as a practical matter, there are certain things and certain patient needs that can't be met by a CNA, and we have to have higher level of nursing help there, and doctors, frankly, of course. So again, it is I think the wise decision in the development of the reimbursement methodology a dozen years ago was to take some of that economic pressure out. So and again, it was important to a lot of the advocates, and I think it's a good thing. So if I am a facility with high labor costs, which probably means either I have a high CNA staffing complement or I have an awful lot of nursing help, I'm not penalized for that. I'm not being, I'm not being forced into a de minimis reimbursement model. I am actually rewarded for spending extra money on staff, and we think that's a good thing. So largely, while nothing is perfect, and certainly in long-term care has many of its challenges, we do think that reimbursement methodology is a wise way to go. That drives a lot of these decisions.
May I ask one more, Mr. Chair, maybe of the author and his witnesses? So if we add this additional cost element to the equation, and I'm not objecting to that, I think our CNA workforce does tremendous work caring for patients and is probably underpaid most of the time. How do we expect to cover the cost of this? I realize this is a policy committee and not a fiscal committee, but on the other hand, we're not unmindful of where we are with our California budget.
Through the chair. First, we aren't sure exactly what the costs are. We've run preliminary spreadsheets, and it's substantially less than the industry has said that it is right now. We aren't sure of what it is and how feasible it is, but we think it's important enough to the people of California that are aging people living the last days of their life often get decent care and have attention paid to them. As Cynthia said, this is where they live, right? So if we decide that's important, if that's our baseline decision, then we figure out how much it costs, and then we figure out how to pay for it. We have some ideas. Like I said, they aren't fully fleshed out because we don't have absolute proof that our numbers are better than theirs yet, and we're working on that.
Well, just to address Mr. Chairman, one more. Just to address the point made about the high acuity patient facility where you, of necessity, have to staff with a higher percentage of registered nurses and LVNs because scope of practice, and the staffing ratios then would call for additional CNAs at that facility. Wouldn't that add to the total cost of?
According to, again, and it's not a law or regulation, but according to the federal report, the highest and best outcomes for the lowest cost come at 2.8 on the CNA level provision of care. For long-term care, people who are the highest usually the highest acuity. People are going to live the rest of their lives out there, and 4.1 in the aggregate. So the ratio we put in matches that.
Okay. Thank you, Mr. Chair. Sorry for taking time.
No, you have every right. Is there anyone else, any questions, comments from any of the members? Is there a motion? Moved by Senator Pan. Oh, I believe did I miss somebody over there?
Yes, thank you, Mr. Chair. Amber King with the Association of California Healthcare Districts. We represent public skilled nursing facilities in remote areas of the state, and we echo the concerns already raised. Thank you.
Thank you. Would you like to close Senator Hall?
Yeah, in consideration of time, I would respectfully ask for your aye vote and want to thank our witnesses who came all the way, most of them from Los Angeles, started at 12 o'clock last night on the bus to come down here. I want to thank them for their attendance and participation. Thank you. Respectfully ask for your aye vote.
Thank you. Item number 23, SB 779, do pass as amended to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall.
Aye.
Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Nielsen, no. Pan. Pan, aye. Roth. Wolk.
Aye.
Wolk, aye. Roth, aye. 7-1.
That currently has 7. We're going to place that bill on call. We're going to go to item number 5, SB 203, Monning. And Senator Monning, I'll let you get up there and then I'll